Differential diagnosis. So what are the other things you should try to see for? So the most common one, as you all know, which is called as supraventricular tachycardia with aberrancy. Aberrance means not normal conduction. Otherwise, sometimes it can be associated with what is called as preexcited tachycardia. Preexcited tachycardia means it is associated with the accessory pathway, or sometimes there's motion artifact, otherwise it is a paced rhythm as well. Otherwise, yes, of course, if it is a VT, which can be further of idiopathic or non-idiopathic type. As I said it is one of the most common, especially if you come across a wide QRS tachycardia. Most of the times you should always think, yes, VT is the reason. But what happens, as I said it, the SVT with aberrancy? What happens? How do you see that? So typically, as I said it, you will be seeing it is associated with a bundle branch block. The bundle branch block can be left bundle or even the right bundle. So then you can see, as I said it, either associated with the left bundle branch or the right bundle branch. So that's pretty easy, right? So what about how the ECG looks like if there is accessory pathway mediated tachycardia and someone is already having a bundle branch block? So if you will try to see this ECG, there's ECG which will be coming to your screen. On this, it looks already wide QRS, as I had said it. And then, of course, tachycardia as well you can see, because when you try to calculate the heart rate for this, you will be noticing the wide QRS as well and the tachycardia as well. And then, how will you say it is not a ventricular tachycardia, as I said it? So if you will see carefully in this, V and A is not associated. So the ventricular conduction is completely independent of the atrial conduction. And that's why you say it as ventricular tachycardia. Now this is another beautiful ECG, I would say. So what happens is, what is the thing, what you notice? So for example, when you look at the V1 and V6, so you can notice it is a right bundle branch block. Then after that, what do you further notice? You notice is the PI interval is very short, right? So the PI interval, so that's why you can always think that this is most likely a AVRT, atrioventricular reentry tachycardia, okay? So you see the heart rate, it is tachycardia. Further, what else do you think of? When you try to see for the VA interval, it is changing, right? So what was happening initially, the VA was 190 milliseconds, but later on the VA became 145 milliseconds. So earlier it was an orthodromic reentry tachycardia, which became to narrow complex tachycardia. Okay, so this is the difference. So this is indeed very exciting, and now coming to some pre-excited tachycardia as well. One of the common things always which confuses a lot of people is manifest versus concealed. So how do you differentiate that? So a lot of times, as I had said it, you will be seeing a shortened PI and is there, delta wave is there. So that's why, yes, you will be knowing, yeah, okay, this is the accessory pathway. But a lot of times you may not be able to see, is it really the short PI may not be present. But what may happen is, only when you have a tachycardia, then you may be able to see. So for example, a tachycardia like this. So in a tachycardia, how will you differentiate antidromic and orthodromic? So orthodromic, what happens is the conduction, the antegrade conduction is happening through the AV node. Okay, antegrade through AV node and retrograde through the accessory pathway. And then what is antidromic? Antidromic, of course, it means is reverse is happening. So in reverse, what is going to happen is orthodromic. It will be going, antegrade conduction will be through the accessory pathway, but it will be going up through the AV nodal, and that is the difference between the orthodromic and antidromic, and that's why it is very important to understand that. A lot of times, especially when you are there in the ER, you may come across some wide QRS tachycardia, but if the RR is interval is varying, So you must try to rule out if it is associated with accessory with atrial fibrillation. And yes, sometimes, as I had already said it, that motion artifacts can be there. Motion artifacts, how do you see is you will be noticing that there is marching of the high frequency signals across the whole wide complex tachycardia. You must be careful when you try to compare whatever recording you see on the ECG. You should try to match it with the other leads as well. So then you will be able to notice it. So that's why it is very important. Okay. Then what about the paced beats? How do you see in the paced beats? What is the example actually over here? So in the paced beats, if you will be seeing the ECG, you will be able to notice that there will be pacing complexes, pacing. So whenever pacing artifacts is going to be there. So if you are able to notice a pacing artifact, you will be able to know that yes, this is a paced beat. So now coming to the most common wide QRS tachycardia, what do you notice? What are the things you will be seeing? It can be of various types, of course, always. And then it can be the most common types of idiopathic, non-idiopathic. The RVOT, LVOT, or fascicular VT are most commonly idiopathic. But the non-idiopathic are ischemic, non-ischemic, hypertrophic cardiomyopathy, or the channelopathies, in fact. Can anyone tell me how do you diagnose a RVOT VT? How do you diagnose it? Anyone would like to say? So why do you say VT? As I had said it, there's V dissociation. Then after that, you'll try to look at the morphology of the V1 to V6. So it will be of left bundle branch block. Then after the left bundle branch block, so you know the origin is in right ventricle. So then you try to look in the axis of the inferior leads, like 2-3 AVF. It is positive, then it is pointing to the outflow tract. Okay? And then this is how you know the RVOT. Similarly, if you try to get a little bit more insight, if lead 1 is positive, it will be directing the origin towards the exit site, and it will be possibly in the posterior median wall actually. Okay, otherwise, of course, in the anterolateral wall. So what are the other things if you see in the ECG, then you know it is a VT? What are the other things? So for example, if on an ECG, if you will be seeing there is capture beat. So if you see a capture beat, you will be knowing this is VT. But how do you say it is a capture beat? Capture beat actually refers, as I had said it, in VT there is AV dissociation. But what will happen is there will be a beat, especially something which will be a little bit slow, which will be when the sinus wave is passing through the AV node and is no longer refractory, so it conducts down the ventricle. And that is why you will be seeing that capture beat. And capture beat, how will you notice this? Because it will be narrow. That's how you will be able to notice it actually. So then what about the other beats? So the other beat is called as fusion beat. In the fusion beat, what happens is it is normally due to the combination of the sinus impulse and also the ectopic impulse, which is leading to a QRS complex. And that's why it is different from the sinus node, and of course different from the premature complex as well. And that's why what you see normally is called as a fusion beat. So yeah, what are the other things? How will you differentiate that? Is it a VT or a right bundle branch block? So what is called as left rabbit ear sign. Okay, so with using this, and if you see a right uh, rabbit ear, then it is VT. So always remember it like this. It is opposite. If it is RBBB, it will not be right rabbit. Do you understand that? So it will be VT in fact. So if it's left rabbit sign, it will be opposite. So that's why this is one of the key things. Okay, I hope, do you all know about this sign? So what are these two signs which you are seeing on your screen? So this is what is called as the Brugada sign and the Josephson sign. So what is it? What are these two signs? So Brugada sign refers when you try to take the distance from the onset of the QRS, okay, to the nadir of the S wave. So which is shown in the red.
Sir, not audible.
Can you hear?
Sir,
hello?
excuse me, sir, not audible.
Okay, just a second. Now can you hear me now?
Hello, sir, not audible, sir.
Now can you hear me? Can you hear
Sir,
me now?
not audible.
Just a second.
Yes, doctor, we are able to hear you, doctor.
Okay, so maybe problem is there with that only single person. So we'll continue. So what I was telling is, so
Sir, not audible, sir.
Dr. Srinivas, kindly check your settings, doctor, because all the other students are able to hear.
Thank
Sorry
you.
to interrupt, Dr. Naren.
No
You
problem.
can just start the session.
Yeah. So as I was telling you, Brugada sign, how do you say it as? You see the distance from where the QRS is starting. Okay? And then from there you go to the nadir of the S wave. I hope you all know which is the S wave. And then you check the distance in the red line, which you see it over here. If this distance is more than 100 milliseconds, this is Brugada sign positive. Similarly, if you see a notching near the nadir of S wave, so this is the S wave, and if you see a notching over here, so if you see a notching, this is what is called as the Josephson sign, in fact. So if you see Brugada sign, if you see Josephson sign, close your eyes and just say, this is VT. And you must be able to proceed. So you notice is V1 is positive, V6 is negative. So it is right bundle branch block. And then, so okay, I won't take you to the type of VT. I'll just tell you this is VT. This ECG, I think I already showed it to you. So this is VT for sure. How do you call it as? As I said it already, there's not just the V dissociation is present, but also the other signs are also present. So what is happening over here? If someone will recall my void QRS tachycardia lecture, you will be able to see or say what is happening over here. So these are the void QRS tachycardia, and in between there is a narrow QRS beat. So what it is? So this is a capture beat, isn't it? How about this beat? What is happening? So the VT was going on, then there was some narrow beat, there was something else as well, and then the VT beat carried on. So what is this beat actually? Sorry. So what is happening is, so this is the first narrow complex is a fusion beat. So why it is called as a fusion? Because these two are the capture beats. And this is morphology wise, this first narrow complex beat, it is a mix of the capture beat and also this one, the white QRS. So that's why it is called as a fusion beat. So this are again characteristics of VT actually. So what do you notice in this ECG actually? So there are two things you have to identify. One is the blue arrow, and the second one is a red caliper. So the blue arrow is a, see, I'm not going to describe you the science in detail because I have already taken a session and I was not allowed to repeat my session. So you must be able to go back and read about it in detail later on, okay? So what do you notice over here? So the red caliper is the Brugada's sign, and Josephson's sign is the one in blue. So what do you see in this ECG now? What is happening to the lead V1? Okay, when you see such kind of, I will give you a hint, if you see such kind of V1 morphology, this is an emergency. You should be alert. So what is this sign? So what is happening is the R dash wave is smaller than the R wave, right? So this is VT again. So this is called as taller left rabbit ear, which is again characteristic of VT. And this one, so this is the same ECG pattern, but it is being seen in right bundle branch block. So you need to be really careful. If you see come across such kind of ECG, you have to be like, okay, this is VT, let's be careful. And one of the common questions where a lot of people get confused is it a SVT with aberrancy or without? So if a ECG is showing a bundle branch block pattern with identical morphology, which is similar to the broad complex tachycardia, this is SVT with aberrancy. Okay. Similarly, you see a ECG when it is showing an evidence of WPW, when the PR is short, broad QRS, otherwise with delta as well, you have to suspect for aberrancy. Similarly, when the patient gives a history of paroxysmal tachycardia, which has already been terminated with adenosine or even with vagal maneuvers, so you have to think mostly for aberrancy actually. Okay. So what is happening now in this ECG? What do you notice actually? So this is a very classical sign. So for example, you must do the measurements properly. So for example, this distance, which is characterized as A, if it is more than 30 milliseconds, it tends to favor more for the VT. And this is what is called as the B sign, which is like the notching. If there's a notching present in the S wave, it tends to again favor VT. And from the starting of the Q till the nadir of the S wave, okay, if it is more than 70 milliseconds, again it tends to favor VT. So only in this slope itself you get so much of information. So just by seeing this, you will be able to tell it is a VT or not. So now, what do you see in this ECG now? If you see this ECG, what is your diagnosis and why? Anyone would like to try? So first of all, this is the tachycardia. Then we try to see from V1 to V6. This is left bundle branch block, right? Axis is normal. So we know this is tachycardia with left bundle branch block. Okay, so what type of tachycardia is it there? Do we see some deflections? So we see there is a regular P wave which is followed by the QRS. And it seems like a short RP tachycardia, right? So short RP tachycardia like this, what it will be? AV and RT, right? And then what is happening in this ECG now? So again, start looking from the basics. What is happening in this? So we notices there is signs of AV dissociation. There is a tachycardia, right bundle branch block. Extreme axis is there as well, north-west axis in the lead 1 and 2. And the RS ratio as well is less than 1, especially in the V6. So which is indicative of ventricular tachycardia, right? So what do you notice in this ECG now? So what is happening over here? No one is trying to guess what is happening over here. What type of... So what is happening is, of course, there is some tachycardia, right? Okay, so but it seems like a little bit like a right bundle branch block pattern. But when we start looking at the rhythm strip, we see each of the QRS is followed by a deflection before it. So this is PQRST, PQRST, PQRST. The PI interval is normal, but there may be one atrial premature beat over here. But even over here, when we look at the rhythm strip, we see it is more of a sinus beat itself. So this is sinus tachycardia. And of course, the incomplete right bundle branch block. And if you try to look at the reasoning as well, I already said it, why it is called as like this. Okay? But if you might have seen the ECG carefully, yeah, there was a Q and T wave inversion in 3 AVF as well, so which will be indicating for the prior infarction. So now, what do you notice in this ECG? This is a true case scenario. So what is happening in this ECG now? So what do you notice is, this is the tachycardia, right? Tachycardia with right bundle branch block. Tachycardia with right bundle branch block, and lead 1 is negative, 2 is positive. So this is again right axis deviation. Right axis deviation, right bundle branch block. Okay. Now let's start to look at the relationship of the P to the there is retrograde P wave, right? After the QRS. So this is more of a re-entry tachycardia, right? But if we look carefully, the P wave is long RP. So if it is long RP, what will you call it as? AVRT, right? So AVRT means atrioventricular re-entry tachycardia, and that happens always due to the accessory pathway. So now moving on to the next ECG. What do you see in this ECG actually? No one wants to try? So you should try to see first of all, is it bradycardia or is it tachycardia? So this is of course tachycardia. Right. So after tachycardia, what next? So what else do you notice? So you notice there are pacing spikes before all the QRS complexes. So this is a pacemaker with tachycardia. What else do you see? So you see is there is negative concordance in V1 to V6. And the initial R wave is more than 40 milliseconds in the V1. And the RS interval is more than 70 milliseconds in the V1. And finally, the QS complex in V6 is present. So what it signifies is this is pacemaker mediated tachycardia. So the origin is happening from the right ventricle and it is a paced rhythm, isn't it? So that's why. Do you understand? So that's why it is called as a RV paced rhythm. You can call it as a pacemaker mediated tachycardia. So what do you notice in this ECG? What is this ECG actually? So what you notice in this ECG is, okay, let's again go step by step. So this is the tachycardia, right? A very fast tachycardia. And mostly, although it seems like, what is happening? So if you look carefully, especially in lead 1 and 2, axis is changing, alternate beats. So this is what is called as it's a rare form of ventricular tachycardia, which is characterized by beat to beat alteration of the QRS axis. So QRS axis shifts 180 degree, literally from left to right with each alternate beat. So this is what is called as a bidirectional ventricular tachycardia. Okay? So most commonly, this tachycardia is associated with severe digoxin toxicity, and it may be the rhythm whenever, so for example, if there is a patient of familial CPVT, catecholinergic polymorphic VT, so those patients can also be having. And yes, if someone is using herbs like aconite, so they may be also having this kind of problem. So now going to the next ECG. What do you notice in this ECG actually? What is happening over here? Again, let's try to go with a systematic approach. So what do you notice is, again, this is a tachycardia, right? This is not a bradycardia. So when you try to look at the hour intervals, you can already notice this is a tachycardia. Then V1 is negative, right? V2 is also negative. Then the transition happens, V6 becomes positive. So what is happening over here? And then similarly, when you try to look carefully in the lead 2 and V1, axis also keeps changing. But also when we try to look carefully, it ectopic morphology is also different. So that's why this will be called as a bidirectional VT with multifocal ectopy. And again, as I had already said it,